So I like to show this slide as in my external cervical resorption section. This was referred to me to evaluate what we needed to do with this external cervical resorption on the distal of tooth number 18. And when we take a look at this x-ray, it really does kind of paint you into a corner. Remember I said earlier that the interproximal areas can be difficult to treat. And this might not be that big a deal because we don't have an adjacent tooth. But definitely that's going to be a long down way below the bone in order to do that surgery. Would we really want to do some sort of internal repair of this where we did the root canal on that tooth to gain access to it? I don't think that would be a great idea. So there really aren't great options. Maybe an option is to not do anything. But remember at the very, very beginning of my talk on resorption, I said that we should never even give someone advice on what to do about cervical root resorption or external cervical root resorption or any resorption without three-dimensional imaging, without CBCT. And remember, our words mean something. If we tell someone, yeah, we're not going to do much about this, but you're probably going to lose that tooth someday, they will actually, many of them, worry about that the rest of their days. Every time they feel something odd down there, and we feel odd things everywhere, but they feel something odd in this tooth and they, uh-oh, is that going to be a toothache? Maybe I shouldn't go to Hawaii next week. Maybe I need to get this tooth out finally. So our words mean something, what we say to them. Our advice, even if we tell them, let's not do anything, means something. So I really felt it was important still to get CT of this tooth. But when we take a look at it, again, this really doesn't look like something that's going to be too fun to treat. However, when we take a look at the cross-sectional imaging, and I love the axial slice to get a good look at what's going on for the resorption, take a good look at this area here and here, because this is where we thought it would be, right on the distal, but there really doesn't appear to be anything back there. But if we take a better look actually at this area here, there is a little scuff in the enamel. And as we go more apically, we can see that the enamel has just been taken off here, probably from the wisdom tooth laying there just a little bit longer than it should. And remember, on your bite wings, enamel is a lot more radiodense than dentin. So if we just take a little bit of enamel off on the buccal, and then we take a two-dimensional projection that only looks over here, and everything in the way of the x-ray beam gets stacked up on our two-dimensional projection, it can look very much like a little ding of external cervical resorption burrowing right in the distal of this tooth, when really it was a harmless little scuff of enamel from the buccal that requires no treatment at all. And this is great information for this patient. Really, you thought, oh, they came in thinking they were going to lose a tooth, and I'm telling you, this is absolutely nothing to worry about because now we've got better imaging. So the other thing that I like to do with resorption sometimes is not do anything. And I am convinced that this entity can be indolent in someone for a very long time, maybe a lifetime, and never cause a problem until we find it, and then we have to decide what to do. I also think a lot of these things I have been speaking about today, where we are talking about all these elaborate treatments to stop resorption, may not make much of a difference sometimes. And we really don't get our minds around the whole concept of treatment illusion in dentistry. We think on a cracked tooth or something, well, gee, we did the root canal on the crown, we got 8 years out of it. That's pretty darn good. And we don't really have any data to know that if we hadn't done anything, what would we have gotten out of it? And the whole idea that if we rush in and do something, well, at least we tried, doesn't really hold up if we look at our evidence. We don't have the evidence of no treatment. But in my practice, I'm starting to get a little bit of it from resorption. I need to have this woman back because it's been a while since I've seen her. But she had 14 different areas of resorption in 2011, and I spoke with him about it, and she was overwhelmed, felt very discouraged, and left. She came back in 2016, and we were able to get new images of them. And this is now 5 years down the road. It doesn't look that much worse. Yeah, it's probably a little worse on tooth number 4, but it almost looks a little bit better on tooth number 3. And remember, these cells actually are trying to put some sort of mineralized tissue in there. It's not dentin, and it doesn't really seal well to the dentin, but it's something that goes back in there. And again, I think on tooth number 4 looks about the same. Tooth number 5, probably a little worse. When we take a look at her upper left, to me, it actually looks a fair amount better on tooth number 12. Maybe pretty much the same on 11. There's something going on here on 14 we really didn't get a good view of on this slice in 2011. Lower, okay, much worse on this tooth. There actually was swelling here. That's why she came back. That tooth needs to come out, tooth number 20. Tooth number 21 probably should come out too, and it might be time for her to look at some implants down here. As we look at the other side, this is now 27. 27 looks worse, but not much worse. These others, there really isn't any change. So I do think that leaving things alone isn't necessarily a bad option sometimes in cervical root resorption. This was a 75-year-old patient, and he was referred to me for me to take a look at the resorption on tooth number 31. And this is what it looked like clinically. And remember I said earlier that sometimes these teeth are in infraocclusion if the resorption happens early on in life. This is a 75-year-old patient. This tooth is in infraocclusion, and I think it is an infraocclusion because of the external cervical resorption that he had on the mesial of tooth number 31. These other teeth then erupted around it. How long has this been there? It's probably been there a solid 65 years, right? Or a 12-year molar. So, 60 years anyway. And it wasn't until a dentist got a three-dimensional view of it that we started worrying about it. I think he's probably going to be okay for another 60. So this is absolutely not something I think we are justified in treating. And remember, resorption comes in a few different ways, internal and external. Internal is pretty easy. We do the root canal for either of them. External is much more difficult to treat. But what's important, I think, about external root resorption is we have these different entities that we discussed: pressure, orthodontic, infection-related apical resorption, trauma, infection-related, replacement resorption, and ankylosis invasive cervical. Only two of them have anything to do with the pulp, yet resorption seems to always get spoken about in the endodontic department. But remember that the pulp isn't involved in anything except these two in the middle that are related to infections and antigens from the pulp space making their way to the periodontal ligament.